Okay, so let's start with one of the most common specimen, the blood. Okay, so blood culture is defined as the collection and inoculation of blood in the culture media with the aim of growing pathogenic microorganisms to diagnose special cases like bacteremia, fungemia, and septicemia. So when we say fungemia, there's presence of fungi in blood. When we say bacteremia, there's presence of bacteria in blood. So there's active multiplication of bacteria in blood. Septicemia would mean there's bacteremia plus the clinical signs and symptoms of bacterial invasion and toxin production. So it's an upgrade. So septicemia is an upgrade from bacteremia. Okay, upgrade for the worst. Okay, so again, the purpose of collecting blood for culture is for confirmation of infectious etiology, to identify the etiologic agent, and of course, as a guide for antimicrobial therapy. Now, there are certain factors that affect recovery of etiologic agent in the blood. So we have specimen collection. For specimen collection, remember, one of the factors that's very important is time. So time of collection is vital. Okay. Contamination. So we have to avoid collecting normal microbiota. Hence, the puncture site should be cleansed properly. Volume. Okay, so volume of blood is critical since the yield is would directly affect isolation of the infectious agent. Okay, that's why we need to collect more than 10 ml for adults. Okay, so the minimum is 20 ml for adults. That's already good for 2 containers. Next, culture media. Okay, so culture media includes inhibitory agents. Okay, so culture media may contain nutrients, okay, chemicals that would enhance the growth of one organism. There are also inhibitory agents that would inhibit the growth of other organisms. Okay. Then we have incubation requirements. So this would include temperature and duration. Okay, so or length of incubation. So when we talk about temperature, of course, as much as possible, we incubate our culture media with the organism on it at 35 degrees Celsius, 35 to 37 degrees Celsius. Sometimes special requirements with special environments would be needed when we incubate them. Like for anaerobes, they would need increased carbon dioxide, and they should be placed inside anaerobic chambers or containers like the candle jar or the gas pack. Okay, and there are those that would need purely oxygen. So those are the things that we have to look into when we talk about incubation requirements. So again, factors that affect recovery of etiologic agent in blood includes specimen. Again, this would cover time of collection, contamination, and volume. Okay. Of course, included here also is the blood and broth ratio. I forgot to mention earlier, and the number of blood culture samples that you need to collect. And then for culture media, so what are the components? Are there inhibitory agents? And then for incubation requirement, that would include temperature, the proper environment, and length of incubation or duration. Okay, so this is where we get to watch, okay, a video on how blood culture collection is done. Okay, so allow me to show you.
Hi there, my name's Andrew. I'm one of the final year medical students. Could I just confirm your name and date of birth, please?
Sure, it's James, 13th of December, 1989.
Nice to meet you, James. James, today I've been asked to take a blood test from you. This will just involve inserting a small needle into one of your veins and taking a sample. and that'll be sent to test for any infection within the blood. Would that be okay?
Yeah, that's fine.
So that's the butterfly method. It's also a closed system. Nice. Remember to dispose your sharps in the sharps bin. And of course, patient care. Do not forget to disinfect after handling.
That's the end of the procedure. Thank you very much.
Okay, thank you very much. So if you noticed, the technician used the butterfly technique or method. That's okay, really. But it's usually used for those with coagulation problems or bleeders. Okay, but for regular patients, those without coagulation problems, they are usually given the syringe technique or the closed system, using the evacuated tubes, or the vacutainer method. So that's best for uh, routine, blood collection. Okay, so here's an update on uh, blood culture contamination. Okay, so a certain study was able to find that coagulase negative staphylococci, viridans streptococci, corynebacteria, bacillus species, as well as propionibacterium species are frequent contaminants, but these are also well-known pathogenic organisms. Okay, so it's not just purely normal microbiota that can grow as contaminants on blood, or blood cultures, but there are also true pathogenic organisms that are frequently present in blood cultures. Okay, so we should be um, in the lookout, for these pathogens. Okay, so moving on to volume of blood. So remember that the volume of blood obtained for each blood culture set is the most significant variable in recovering microorganisms from patients with bloodstream infections. Okay, so one set is 2 tubes, one is aerobic and one anaerobic tube. So you've seen that earlier in the video. Okay, so for adults, one tube is 10 ml. Okay, so we need to collect at least, the least is one set or 2 tubes. Okay, but it is best if you can go as far as or as many as 60 ml. That would be equivalent to 3 sets. Okay, but of course, the sets are collected from different sides of the body. Okay, so say one set is in one arm, the other set in another arm, and then the last set is from a leg vein. Okay, so that would be best. Okay, so the more blood volume to be examined, the greater the chances for you to be able to isolate organisms. So this is because it is known that generally adult blood has relatively low colony-forming unit per ml. Okay, so adult blood, again, has relatively low colony-forming unit per ml. Okay, so again, it is best to collect as much specimen as possible. Okay, so note, a single blood culture per day is not recommended. Okay, so at least more than one bottle, at least more than 10 ml. No? So you need at least one set, 20 ml. Okay. For pediatric patients, you can go as low as 5 to 10 ml. For neonates, it's about 1 to 2 ml. For 1 month to 2 years old, 2 to 3 ml. And then for children below 10 years old, 3 to 5 ml. Okay. Now, moving on to the number of blood culture sets. So, how much sets, or how many sets rather, are we supposed to collect? So, start with 2 or 3 sets of blood culture bottles. Remember, one set is 2 bottles. Okay. So, one aerobic, one anaerobic. Okay. Now, if you're going to go for 2 sets, so you'll have 2 aerobic bottles and 2 anaerobic bottles. Okay. So that would be for each septic episode. How would you know on a septic episode? No, so we have to watch out for the times when the patient's temperature would spike up. That's a telltale sign that the organisms are trying to increase in number or are in their their doubling time or generation time period. Okay, so 2 to 3 sets per bottle. Okay, per septic episode. Now, if the culture comes out negative after 24 to 48 hours of incubation and the patient is still potentially septic without an identified source, collect another 2 to 3 sets. Okay, so then incubate. Now, if the culture comes back negative again after 24 hours of incubation, this is what you're going to do. Investigate non-microbial etiology. It could be viral. Remember, viral organisms do not respond very well on culture media that we use for bacteria. They don't just grow on any environment. And then try to prolong incubation time. Sometimes there are organisms that would be present after 21 days of incubation. So that could be it. Okay. If not, call and inform the physician and ask if you could, again, repeat the process the 3rd time around. So it's the doctor's call after your 2nd trial. Okay. So that's how many sets you're supposed to collect. Okay. 2 to 3 sets per septic episode. If it comes out negative, you can collect again, and then incubate again. And then if it comes out negative, try and get the help of the physician. Okay. So if, for example, there's only one tube that turns out to be positive, okay, what are you supposed to do? Now, if, for example, the pathogenic organism that you have identified in that positive bottle is Listeria, Staphylococcus, Brucella, Haemophilus, or Enterobacteriaceae, that could be a probable bloodstream infection. Okay. Now, if, for example, you were able to isolate viridans streptococci or coagulase negative staphylococci, that's usually consistent with clinical setting, like the patient is positive for indwelling catheter or prosthetic devices, or the patient is immune compromised, then that would still be a possibility of bloodstream infection. However, if your positive bottle comes up positive only for Propionibacterium, Corynebacterium, Bacillus, coagulase negative staphylococci, remember this is the update, no? So it could be a probable contamination. So what you can do is you can repeat collection, repeat the procedure, or you can consider infectious, non-infectious etiology or viral etiology. Or there could be a bacteria that cannot be cultured that's present in your organism, your specimen, okay? So these are the things that you need to do, okay? So again, if it is if the organisms present or identified in your single positive bottles are this or this, then that could be a bloodstream infection. So proceed, no, to sensitivity testing. Okay. If this one is the result, that could probably or simply be a contamination. So you can repeat. If not, you can check out non-infectious etiology, or you can investigate viral etiology. Okay. Now, what are the samples for rejection? Okay. Of course, we cannot process clotted samples, so that's rejection. Okay. Specimen collected using only alcohol as antiseptic. Remember, our normal microbiota on the skin has been exposed so many times to alcohol. Okay, sometimes they become oblivious to the effect of alcohol. So that's why we usually use a tincture of iodine as additional precautionary measure when we clean the area for blood collection. Okay, so if the sample has only been collected or from a site that has been cleansed only with alcohol, then that too will undergo rejection. Okay. Now for adults, the requirement is 20 ml at least. If the specimen submitted is less than 20 ml, then that sample is also up for rejection. Okay. Next, blood to broth ratio. So usually the recommended ratio is about 1:10. Okay, so 1:10 for most blood culture bottles. It's 1:10. Okay, so we dilute the antimicrobial and inhibitory substances in the blood with the culture media or the broth. Okay. However, there are commercial continuously monitoring blood culture systems that may use blood to broth ratio of 1:5. Okay, that ratio also works, especially because it's a culture system, no, a machine. Okay, so that also works. Okay. Now moving on to culture media. Okay, so for culture media, we have the glucose broth, the bile broth, the trypticase soy broth, brain heart infusion broth, thioglycolate broth, and the Colombia or Brucella broth. Okay, the glucose broth is perfect for or ideal for endocarditis. Okay, bile broth is ideal for samples from patients with enteric fever. Trypticase soy broth is not for samples that may contain Neisseria and Streptococcus pneumoniae. Okay. Instead, you can use the brain heart infusion broth for that, no, because this is a multi-purpose broth. And then for anaerobes, the best broth would be thioglycolate. And then for Brucella, of course, you have the Colombia or the Brucella broth. Okay. Usually, this culture media would contain sodium polyanethyl sulfonate. So this is an additive that's usually incorporated into these culture media at a concentration of about 0.025 to 0.03%. So this additive, no, sodium polyanethyl sulfonate or SPS, has anticoagulant, antiphagocytic, and anti-complementary action. It can neutralize bactericidal effect of serum, and it can activate certain antimicrobial agents. However, okay, examples of antimicrobial agents that can be inactivated rather by SPS would includes gentamicin, kanamycin, streptomycin, and polymyxin B. Okay. However, there's a downside to SPS. Okay. It's quite toxic to certain fastidious organisms like Neisseria, Mycoplasma, Peptostreptococcus, and Streptobacillus moniliformis. So if you're trying to isolate these organisms, use 1 to 2% gelatin, or you can use penicillinase. This one, of course, is used to inactivate penicillin, or what's common nowadays, and it's usually incorporated in blood culture bottles, that comes with automated machines. They have the resin or charcoal. Okay, so this usually inactivates most antibiotics by absorbing those antibiotics into the surface of the resin. Okay. Of course, we have osmotic stabilizers like sucrose, mannitol, or serbose. They're actually quite efficient for cell wall deficient bacteria, okay, like Mycoplasma. But osmotic stabilizers are known to lyse, RBC. So we have to be careful of that as well. Okay, now moving on to incubation. Okay, so remember, this is the last factor. Okay, so incubation would include temperature and the length or duration of incubation. So usually the temperature is around 35 degrees Celsius to 37 degrees Celsius. Subculture is usually done on blood agar plate and chocolate agar plate. Okay, and they are usually incubated under carbon dioxide enhanced atmosphere. Okay, so usually subculturing occurs after 14 to 17 hours of incubation, and then again on the third day, and then again on the fifth day. So 3 to 5 days of subcultivation is sufficient. We don't need to subculture more than 7 days, okay? Because it would be prone to contamination. However, subcultivation on the 7th day is quite useful for fungimia, for agents of bacteremia like the HACEK group. Okay, HACEK group is HACEK. This is short for this. It's an acronym for Haemophilus, Aggregatibacter, Cardiobacterium, Echinella, and Kingella. Okay, and then Brucella and Legionella as well. Okay, and then of course, mycobacterial cultures usually grow after more than 4 weeks of incubation. So there's that. Okay, so ideally 5 days of subcultivation is enough, but then again, there are those organisms that would require longer incubation period. So we have to know, and to follow their incubation requirements. Okay, now moving on to blood culture methods. So blood culture methods include, of course, traditional or conventional systems. So in the traditional method, the culture media are manually prepared, the organisms are manually subcultured, and the gram staining process is also manually done every day or every other day. Okay, so what we usually check out, what we usually do watch out for to know if there's bacterial growth. We check for turbidity like this. Initially, this culture media is clear yellow. Now it's turbid. Okay. Hemolysis is also a positive sign of growth. Okay. gas production like this, no? So the bubbles. And then pellicle formation. Pellicle is similar to colony, but on liquid media. So this is pellicle formation, and it can be found on the surface of the broth. Okay, then we have commercially developed systems like our biphasic septic check system. So this one has an agar slant attached to the broth containing bottle. So this is the agar slant and this is the broth. Okay, so it allows the subculturing to be done in a closed system. You don't need to open the container just so we could subculture on the agar. Okay, you simply tilt the bottle to allow the broth to flow on the surface of the agar to allow the organism on this broth to at least grow on the culture media. Then we have the oxoid signal broth displacement system. So this one comes with a cylindrical signal device that's attached to the main bottle with a long needle, extending to the surface of the broth here. Can you still see it? Right? So it's also a closed system. Okay. Now, if there is bacterial growth, okay, it would cause gas production. Okay. And when gas is produced, it increases the pressure inside the system. Okay. So this would cause or force the blood mixture, some of the blood mixture into the cylinder right there at the top of the main bottle. Okay. And the presence of blood in this container is a signal of a positive blood culture. Again, if there's organisms living in it, in the specimen, okay, gas will be produced. And when there's enough gas, it will cause an increase in pressure. No? So blood will come up into the needle and up into the cylindrical signal device. Okay. Then we have the automated detection system. Okay. So this includes BACTEC, Bacti Alert, and TREC ESP culture system. So these systems alert the laboratory when the culture is positive, and you can process a lot at one time. Okay. So when the alert goes off, it's time for you to gram stain and subculture. So you'll know, if there's you'll know what to do next because the machine will alert you. Okay. So let's start with BACTEC. Okay. So again, this is a video that would show us, how it is how to use this in the laboratory. Mind you, this is a product demo. So let's start somewhere significant. Somewhere here. Okay.
The BD BACTEC FX and BD BACTEC FX40 instruments with scalable footprints allow for a simple, rapid workflow for incubation and continuous monitoring of blood culture media. Using unique sensing technology and detection algorithms, the BD BACTEC instrument will identify specimens as being either positive or negative. Positive blood cultures are communicated to the laboratory via automated audible and visual alerts, as well as through the BD Synapsys Informatics solution.
Okay, so that's how BACTEC works. Okay, it signals, it lights up, and then it actually creates a bell-like sound, to indicate that one of the cultures inside the machine has come out as positive. Okay. And then it also is reflected into the computer system that goes with the machine. So a lot of this automated system actually comes with a machine. Okay. Now let's check out the Bacti alert system. Again, this is a product demo. So let's start somewhere.
The BacT-Alert 3D is easy to use. Just touch, wand, load. The built-in barcode reader and touchscreen makes scanning and loading samples simple and convenient. By ingeniously combining several proven advanced technologies, BacT-Alert 3D is the hallmark of automated microbiology culture instrumentation. bioMérieux's unique patented microbial detection system starts with this deceptively ordinary-looking culture bottle, but this bottle is far from ordinary. It features bioMérieux's advanced colorimetric detection system, one of the fastest, most accurate detection systems in the industry. The sensor at the base of each culture bottle detects carbon dioxide production, changing from gray to a lighter color when carbon dioxide is detected. A light-emitting diode within the BacT-Alert 3D scans the bottle sensor every 10 minutes to detect even the slightest change in color. As more carbon dioxide is produced, more light is reflected. Samples are monitored individually, and a high rate of carbon dioxide production or sustained acceleration of carbon dioxide production is required for a positive reading. When positive cultures are detected, the BacT-Alert 3D controller immediately alerts you with visual and audible signals and identifies the location of the positive cultures. If carbon dioxide production does not change significantly after a user-specified number of days, the sample is determined to be negative. With BacT-Alert 3D's advanced technology, each sample reading is compared to its own prior performance, rather than a predetermined system threshold. On this graph, the vertical white lines show the different ways the system determines cultures to be positive. BacT-Alert 3D reliability and accuracy have been proven in labs around the world, and documented results by independent researchers have been published in many peer-reviewed journals.
Okay. No, so this is also quite a machine. No? So it also allows the laboratory to observe, and await for positive outputs. Okay, so you don't need to go and check in on it every time. Okay, except of course if there are error signals. But when positive cultures are present, they would give out a signal, sound signal, and then visual signals as well. Okay, so the machine would also light up. Same with the computer system that's attached to it. Okay, so the principle of this one is quite easy. Okay, so if organisms are present, they again create gas. Carbon dioxide is liberated. When carbon dioxide has been produced by the organism, is sensed by the diode. Okay, it would cause change in the color of the chemicals at the bottom from gray to something that's light like yellow or peach. Okay, and that would alert, the machine would alert the laboratory. Okay, so quite interesting. Okay, so once it alerts us for a positive output, then that's our signal to take out the bottle and perform gram staining and sub-cultivation as well. Okay. Now, what are the advantages and disadvantages of continuous monitoring systems like the BacTech and the BacT-Alert? Okay, so of course, there's decreased laboratory work. Okay, the lab work is more efficient. There's an automated machine in the lab. It cuts our workload. Okay. It decreases the cases of pseudobacteremia because there's decreased number of sampling and handling. Okay? And of course, it increases the speed of detection and rate of recovery. However, okay, these types of systems would require an instrument. And those instruments are really expensive. And also, there's a limited selection of culture media that can be used with the machine. So if you don't have it, or it runs out of supply or out of stock, then you cannot use the machine. Okay, now let's move on to our next specimen. We have the respiratory specimen. Okay, so respiratory specimen could be from the upper respiratory tract, or it could be from the lower respiratory tract. Okay, so for upper respiratory tract, specimens would include throat swabs or nasopharyngeal swab or nasopharyngeal aspirate. The usual pathogen of infections in the upper respiratory tract includes Streptococcus pyogenes, which is the agent of streptococcal pharyngitis. We have Corynebacterium diphtheriae, which is the agent of diphtheria. Haemophilus influenzae type B, which is the agent of epiglottitis. However, there are lesser number of cases of epiglottitis today because of successful immunizations of HIV. Okay. And then we have Neisseria gonorrhoeae, which is the agent of gonococcal pharyngitis. There are also organisms that can be asymptomatically carried in the upper respiratory tract of some individuals. That would include Staphylococcus aureus, Streptococcus pneumoniae, Moraxella catarrhalis, Bordetella pertussis, and Neisseria meningitidis. Okay, so throat swabbing. Okay, so throat specimen can be acquired through swabbing. So we rub the swab as much as possible. Again, not cotton swab. They produce fatty acids that are usually detrimental to organisms. Okay, so we use dacron or rayon swabs. Okay, so we rub the swab across the tonsillar area. Okay, here. And then the posterior pharynx also, okay? Especially if the areas are inflamed. So we allow our swab to touch those inflamed area. But remember, of course, to avoid normal oral flora, no, like those that can be seen at the roof and the sides of the mouth, and of course the tongue. Okay, so do not let your swab touch any of those surfaces. Okay, so for the culture media, we can use blood agar plate for isolation of Streptococcus pyogenes. We can use chocolate agar plate or blood agar plate, usually strict with Staphylococcus if you're going to isolate Haemophilus influenzae. And then we have chocolate agar plate and Thayer-Martin medium for Neisseria meningitidis. And we have the charcoal cephalexin medium for Bordetella pertussis. Okay. And then we have nasopharyngeal secretions. Okay. So for nasopharyngeal secretions, we can do swabbing or aspiration. So for swabs, we use two sterile swab. Again, dacron rayon or calcium alginate swab. They're also fine. No, they usually contain no fatty acids that can inhibit the growth of many fastidious organisms. And then for aspiration, okay, you can use mucus extractor that's connected to an NGT. However, the good thing is that we're not the ones to perform nasopharyngeal aspiration. Nowadays, we can perform swabbing. No, the medtechs can perform swabbing. But for aspiration, it would require the expertise of physicians, ENTs. Okay. Then moving on to lower respiratory tract specimens. We have sputum, we can do endotracheal aspirate, bronchoalveolar lavage, or bronchoscopy secretions. Okay. So for the last three, okay, so with the exception of the sputum, the last three specimen would require, again, the expertise of a trained individual. Okay, so the pathogens that we usually isolate from lower respiratory tract specimen includes Streptococcus pneumoniae, Enterobacteriaceae like E. coli, Klebsiella species, Serratia species, Pseudomonas aeruginosa, Staphylococcus aureus, Legionella, Mycobacteria, and Mycoplasma species. Okay, so collection, especially for sputum, okay, especially for sputum specimen. Okay. We need a dry, wide-mouth bottle, ideally with screw caps. The best time to collect your samples would be early in the morning, where there's a higher chance of collecting purulent samples. And then, of course, transportation should be done as soon as possible. Usually, collection can also be done within the laboratory premises. Okay. And you may refrigerate sputum samples, but it needs to be examined within 2 to 3 hours. Now, remember, okay, it's very important to be able to assess samples before receiving it into the laboratory for assessment. Okay, so saliva is not accepted. Okay, so this shows purely saliva. So this is pure quality sample. Okay, blood-stained samples, purulent samples like this, or mucoid samples like this are usually accepted for laboratory assays. Okay, so be very familiar with how saliva looks like and how it is different from purulent samples. Okay. Now, even if it has been assessed, in the receiving area, it does not mean that your specimen can be submitted for culture right there and then. It needs to pass through suitability testing for culture. Okay, and this is done using the Bartlett's sputum classification, wherein, okay, the specimen that's suitable for culture should have less than 10 epithelial cells and more than 25 pus cells. Now, this is an example of the Bartlett's classification. Okay, so number of neutrophils or WBCs or pus cells per low power field. Okay, they're usually graded. Okay, same thing with the number of epithelial cells per lower field. Okay, so if, for example, the number of neutrophils that you were able to count in LPO is fewer than 10, the grade given for that sample is 0. If you were able to count 10 to 25 neutrophils per LPO, the grade given is usually +1. But if you're able to count more than 25 neutrophils per low power field, then the grade given is +2. And if you're able to see mucus threads, then that's +1. Okay. Now, for the number of epithelial cells per low power field, if you're able to count 10 to 25 epithelial cells per low power field, that's -1. If you were able to count more than 25 epithelial cells per low power field, that's -2. Where to minus? From the grade given here. So say, for example, you were able to count greater than or more than 25 neutrophils per LPO. So the grade given here is +2. And then the sample is highly mucoidal. So that's +1. So you have +3 in this area. Okay. And then the number of epithelial cells that you have counted per low power field is 12. Okay, so that's -1. So +3 -1, that leaves you with +2. Okay, so that sample is good for culture. However, okay, if you were able to come up with fewer than 10 neutrophils per low power field, that's 0. And you were able to count about 10 epithelial cells per LPO, that's -1. So you come up with -1. Okay, so that's less than 0. Okay, so your specimen is not suitable for culture. You'll have to call the patient back in for repeat collection. Okay, so that's your suitability test for culture prior to performing the actual procedure. So say, for example, your specimen has passed the Bartlett's classification, then you can proceed to making your smears. So prepare your smears. Okay? You'll be performing gram staining and acid fast staining. Okay. Now, if, for example, your acid-fast smears turn out to be negative, okay, do not report it as negative immediately. First, do digestion and concentration technique. Maybe the organism is there, it's just that it's wrapped around fats, no, and other proteinaceous material, covering, your vision. So you're not able to identify them on the smear. So why not remove, okay, other materials to expose the acid-fast organism? Okay, so use the NaLC, NaOH technique. So N-acetyl L-cysteine sodium hydroxide method. This technique will dissolve the fats in the mucus to free the acid-fast bacteria. Okay, and then after your digestion procedure, perform acid-fast staining. So if it comes up positive, then proceed to culture. Okay. Next, we have urine. Okay. So the purpose of performing urine cultures is to diagnose urinary tract infections. So there are several methods of collection, but the most widely identified method of collection is the clean catch midstream method. So this is simply done by cleaning the area first. So the periurethral area is cleansed with soap and water, and then it's wiped dry. And then the first few ml of specimen that's released is usually discarded. Now, this is to allow bacteria to be flushed from within the urethra. And then the midstream portion is usually collected. Here, the specimen is also collected in a wide mouth bottle with screw cap. Okay. And then apart from the clean catch midstream method, we can also use the suprapubic aspiration technique. This is widely used for young children, okay, or infants. This is an invasive procedure, so it's only performed when absolutely necessary. Okay, so again, the needle is inserted directly into the urinary bladder to collect sterile urine. Okay, and then sometimes cytoscopy methods or catheterization can also be accepted, when urine samples are collected for culture. Now, the ideal time for collection is early morning. Hence, the best specimen is early morning midstream clean catch. Okay, so the processing time is ideally within 1 hour after collection. Okay. So, processing of urine includes gram staining of uncentrifuged urine. We do this for rapid UTI screening. Okay, so if there's numerous squamous cells seen, that usually mean vaginal or urethral contamination. Okay, so for culture, initially we inoculate samples on blood agar plate. EMB is eosin methylene blue agar and McConkey. Again, that's blood agar plate, eosin methylene blue agar, and McConkey. Okay, and we usually use a calibrated loop. So calibrated loops can be 1 microliter or 10 microliter. So you can use either, but usually they use, in most labs, they use 1 microliter loops. Okay, so we inoculate 1 microliter of urine sample onto blood agar plate, EMB, and MAC. We incubate that overnight at usually 35 degrees Celsius. And then the next day we observe for growth. And then we count the colonies. Now, if our cultures come out negative, we re-incubate those culture media for another 24 hours. Okay, so if, for example, you have your colonies counted, okay, so you have your colonies counted, you simply compute for colony forming units per ml. Remember, our formula, the unit here is per ml, and the loop that we have used is microliter. Okay, so to come up with microliter, to come up with ml rather, milliliter, we have to convert. Remember, there's 1,000 microliters in 1 ml. So our calibration here is 1,000 for 1 microliter. If you're going to use the 10 microliter, then your calibration here is 100 because there's 100, 110 microliters in 1 ml. Did you get that? Okay, so if you're going to use the 1 microliter, your calibration factor is 1,000 because there's 1,000 of 1 microliter in 1 ml. Okay, so an outcome of more than 100,000 bacterial colony forming unit per ml signifies infection. Okay, so for example, using your 1 microliter loop and you have counted 25 colonies, what is your colony count? And then what if using the same microliter, using the same loop, 1 microliter, you've counted 145 colonies, what is your colony count? Okay, so 25 colonies using your 1 microliter, so the calibration factor for that is 1,000. Again, because there are 1,000 1 microliter in 1 ml. Okay? 1,000 ka 1 microliter sa 1 ml. Hence, our factor is 1,000. Okay? So, colony counted, 25 times 1,000. That's 25,000 colony forming units per ml. Now, what about the 145 colonies? So, you were able to come up with 145 colonies. And you have used your 1 microliter loop, that's still 1,000. So 145 times 1,000, that's 145,000 colony forming units per ml. Okay, this one is negative for infection. This one, however, is positive for infection. Okay, now there's another method here that you can use for urine culture. We have the pour plate method. Okay, so initially prepare a 1:1,000 dilution of urine with sterile distilled water. Okay, so how will you do that? Okay, so your original inoculum. Okay, so gather 1 ml, collect 1 ml of urine, transfer it into a tube containing 9 ml of your sterile distilled water, or you can use broth, no? Pero it depends on the SOP of your laboratory. So if you are using sterile distilled water for your pour plate method, then go with that procedure. Okay, so 1 ml of your urine sample, combine it with 9 ml of sterile distilled water. That would make 1:10 dilution. Okay. Now, from this 1:10 dilution, collect 1 ml, move it into another tube containing 9 ml of distilled sterile water. That would give you a dilution of 1:100. Okay, now again, since you'll be needing 1:1,000, transfer 1 ml from this container into a third tube containing, again, 9 ml of sterile water, and that would give you 1:100. Okay, transfer 1 ml of your 1:1,000, rather, 1:1,000 dilution into a Petri dish, and then add nutrient agar. Mix it well. Make sure it's not too warm. Incubate for 18 to 24 hours. Okay. And then count the colonies. And then multiply it by 1,000. Okay. And then you report your result in bacteria per ml. So that's your pour plate method. Okay, so remember, values that's greater than 1 by 10 to the 5th colony forming unit per ml indicates infection. Values of 1 by 10 to the 3rd or 1 by 10 to the 5th colonies per ml, it could mean contamination, or the patient is now convalescing from UTI. Okay. Now, if you're going to use your 10 microliter loop, the colonies count, the formula you're going to use is colonies counted multiplied to 100. Again, because there are 110 microliters in 1 ml. Okay, so that's going, 100 is going to be your calibration factor. So more or less, usual organisms isolated in urine cultures is E. coli. So 90% of UTI cases is positive for E. coli. Okay, so other than E. coli, we have Klebsiella, Proteus, Enterobacter, we have Pseudomonas, and we have Staphylococcus saprophyticus, and sometimes yeast, can cause UTI also. Okay, now moving on to CSF. Okay, so samples should be collected before treatment. However, CSF should always be taken from patients with suspected purulent meningitis, regardless if they have taken antibiotics already or not. Okay, we have to avoid delay because there's high mortality rate and rapid proliferation of the microbes that are usually associated with meningitis. Okay, the major pathogens that can be isolated from CSF are usually Streptococcus pneumoniae, Haemophilus influenzae type B, and Neisseria meningitidis. Okay. Okay, so CSF is collected by lumbar puncture, usually between the 3rd and the 4th lumbar vertebrae. And this is done by an expert, a physician or an anesthesiologist may collect this. Okay, so the volume that is usually collected may range from 0.5 to 5 ml, averaging between 3 to 4 ml. Okay, so collect 3 tubes. Okay, choose tube 2, or the most turbid sample for microbiology assays. The 3rd tube can also be used if it is devoid because it is devoid of skin contaminants, as it is the 3rd tube already. Okay, so if you have multiple microbiology assays to be performed on it, so you can divide, CSF. 1 ml for culture, 2 ml for fungal culture, bacterial culture, 1 ml for bacterial culture, 2 ml for fungal culture, and 2 ml for bacterial culture, if you were able to isolate or collect as much as 5 ml. Okay, but if the sample is scanty, okay, you'll have to preserve that volume for microbial culture. Okay, so if you have more, you can perform chemical tests, serological tests, and hematological tests as well. Okay. Ouchie. Okay, so normal CSF is usually clear and colorless. So when you perform macroscopic examination, you have to record the volume. Okay, you have to record the color and the appearance. Okay, so when you say appearance, you can check whether it's bloody or cloudy or xanthochromic. When you say xanthochromic, the CSF appears yellowish. Okay, so xanthochromia is a yellow pigment in CSF that is usually present due to the presence of bilirubin. Okay, now when the CSF is cloudy, that means there's also infection. Okay, so the procedure for cultivation is as follows. So initially we centrifuge the CSF and then we work with the sediment. Okay, so we culture the sediments on the following culture media. No? So we use TSB or trypticase soy broth or thioglycolate. And then we watch out for blood agar plate for, we use blood agar plate for isolation of gram-positive cocci, chocolate agar plate for isolation of gram-negative cocci, and then we grow them on EMB and MAC for gram-negative bacilli, okay? And then the remaining, if we still have remaining samples, or you can work with the supernatant, you can use that for serological testing, okay? And the remaining sediments can be used for gram staining as well as India ink, okay? Okay, so this is a flowchart of CSF processing. So if the CSF has reached the laboratory in less than an hour, you can centrifuge that at 2,000 rounds per minute for 20 minutes. And then you separate the supernatant and the sediments. With the sediment, you can do your culture, no, primary plating on your chocolate and your blood agar plate, and then the remaining for gram staining. The supernatant is usually reserved for latex agglutination. Now, if your CSF has reached the laboratory beyond an hour after collection, inoculate it immediately into trans-isolate media and then incubate it overnight at 35 degrees Celsius in carbon dioxide. Okay. And then the next day you can subculture to chocolate agar and blood agar plate. Okay. Now for delays in CSF processing, no, remember that you can always incubate your samples at 35 degrees Celsius for not more than 12 hours in some references and 6 hours in some references, or you can stand it at room temperature for not more than 1 hour. So this is true for bacterial culture. Remember, do not refrigerate because there are organisms that may be present in your CSF that are known to cause meningitis, like your N. meningitidis and H. influenzae. They're quite sensitive to low temperatures. They might die when you refrigerate the specimen. Okay. Now for viral culture, there's actually no problem. You can refrigerate your specimen. You can even deep freeze it for more than 24 hours, even months at a time, no, at negative 70 degrees Celsius. Okay. So for bacterial culture, the organisms are sensitive. Do not refrigerate. You may incubate or stand at room temperature. But for viral culture, you can deep freeze or you can refrigerate. Okay. Now moving on to stool. Okay. So bacterial infection of the stomach are actually quite rare because of the acidic pH. So most gastrointestinal infections involve the intestines. Okay. So for gastroenteritis, stool is actually quite ideal. The collected stool is best for when it has been collected during the early stage of the disease. Okay, sometimes you can also opt for rectal swab. Okay, and then apart from rectal swab and stool, if you'd like to isolate acid-fast bacilli from other specimen, you know, aside from sputum, you can opt for gastric aspirate. And then if you'd like to isolate Helicobacter pylori, gastric biopsy would be the best specimen and not stool culture. Okay. So the amount usually is 1 to 2 grams. Container used is similar to urine sample, no, wider. The mouth should be wider. And of course, screw cap. Okay. Transport time maximum is 2 hours, but it is still best to submit your samples an hour after collection. Okay. And then you can refrigerate it for 24 hours at 4 degrees Celsius. Now, if you need to culture it before it is transported, you can use the Carrie Blair transport media. That's usually good for stool sample. Okay, so the procedure, if you're going to use the rectal swab, okay, after swabbing, put it immediately into a tube containing enrichment broth, like selenite broth. Okay, we don't usually perform gram stain on stool samples because we know for a fact there are plenty of normal microbiota there, but it helps in identifying possible etiologic agents. So if we come up with, if we are to perform gram staining, you may come up with gram-positive cocaine clusters, gram-negative comma-shaped bacilli, gram-positive bacilli in large numbers, and gram-negative bacilli. So first day of stool culture, inoculate the specimen and incubate it overnight at 35 degrees Celsius. Now, the culture media we usually use for inoculation on the first day are a variety of differential, selective, and enrichment media. So for differential media, you can opt for asin methylene blue and McConkey. For selective media, you can go for Salmonella, Shigella agar, Hectone, enteric agar, and Xylose lysine deoxycholate. Okay? Again, Salmonella, Shigella agar, Hectone, enteric agar, and Xylose lysine deoxycholate. Okay? Enrichment media, you can opt for selenite F or alkaline peptone water. This is actually much more common. Okay? And then day 2, you remember day 1, you inoculated and then incubated your specimen. Day 2, take all your culture media from the incubator and check them out. No? So check your enrichment tube. It could be selenite F or alkaline peptone water. What are you going to check? What are you going to check it for? Check for turbidity. If there's turbidity, that means there's positive growth. If it's still clear, negative. Okay, now check your differential media and your other culture media as well. Okay, check if there are colonies and note whether they have pigment or not. If you have pink or purple colored colonies, those are lactose fermenters. No? So lactose fermenting organisms are able to produce pink colored colonies or purple colored colonies on either EMB or MAC. Now, if there are colonies but they're neither pink nor purple, they're colorless, but there are still colonies, so they're usually produced by non-lactose fermenters. Those that are able to ferment lactose in the culture media may produce colored colonies. Those that cannot ferment lactose in the culture media cannot produce colored colonies. Okay, so either way, there's growth, so there are organisms present. Okay, so if there are growth on your differential media, what are you going to do? On the second day, subculture it into another set of culture media. No? So both your plated media and tube media. And then do biochemical test. No? After you do your biochemical test, incubate those as well. Okay? So your second set of culture media, no, MAC, EMB, and then your SSA or whatever it was that you used, and your tube media, plus your biochemical media, incubate them. Now, what if there is no growth on the second day? So what are you going to do? Inoculate culture from enrichment media into another set of EMB or MAC. So if you have no growth on your differential media, get your APW or your selenite F and culture it into another EMB or MAC plate. Okay, and then incubate. Now, moving on to day 3. So what are we going to check out? So if on the second day you were able to find growth and were able to do biochem, you note the patterns of biochemical reactions. Record it. If the biochemical reactions that you were able to come up with are suggestive of Salmonella, Shigella, Vibrio, perform serological typing and then record the results. You may report it as well. Okay. Now, what if you had no growth on the second day? Remember what you did? You subcultured, no, from your APW or your selenite F, you subcultured it into another set of EMB and MAC. So on the third day, you're going to check your EMB and MAC. And if there's growth, record the results and do biochemical test. Incubate your biochemical test. And remember, you also need to subculture it. So incubate that too afterwards. Incubate overnight and then perform step 1 and 2 of day 3. Okay. So moving on to our next specimen. We have exudates and transudates. Okay, so transudate are fluid buildup, usually caused by systemic conditions that may alter the pressure in blood vessels, like the fluid in the lungs have increased in volume, making it difficult for the patient to breathe. So you can collect the specimen from there. Okay. So transudates are usually clear like water or slightly light yellow. Okay. Exudates, on the other hand, are also fluid buildup, but this one is caused by tissue leakage due to inflammation or local cellular damage. They're usually bound to be more cloudy, sometimes bloody, okay, higher concentrations of protein and other substances on exudates. Okay, so here are examples of transudates and exudates. When we say transudates, so these are body fluids actually. Okay, so you have synovial fluid, pleural fluid, pericardial fluid, peritoneal fluid, or hydrocele. So these are basic body fluids that has simply increased in volume. That has the volume has become abnormal. Yeah, so you can collect and process. Exudates, on the other hand, okay, includes wounds, wound samples, boils, pus, abscesses, ulcerations, samples from ulcerations, granules, rashes, okay, eye and ear discharges, endocervical discharges, urethral and anorectal discharges, okay? And so to differentiate your transudates and exudates further, on appearance, again, transudates are clear like water. They may be sometimes pale yellow, but exudates are turbid or bloody. Also, exudates contain a higher percentage of total protein, serum lactate dehydrogenase, okay? And then higher cholesterol and higher specific gravity, okay? So for collection methods, so for discharges, we have for wound and skin lesions, for dry wounds, remember to moisten the swab. You can use NSS before collecting. Now for skin lesions like those in herpes, okay, you can remove the crust of the pustule or the vesicle and then gently swab the lesion. And then for superficial wounds, okay, collect along the edge of the wound after cleaning with sterile water. Okay. For deep wounds, use needle aspiration. So needle aspirate is the best method for deep wound because this will avoid contamination of normal microbiota, and also it enhances recovery of anaerobes, which are often associated with wound infections and abscesses. Okay. For endocervical samples, urethra and anorectal, you can go for a swab. Okay? Remember, you have to collect 2 swabs. Okay? So this is usually done by an expert again. Okay, for endocervical and anorectal, this can be done by physicians, okay, or OB-GYN. For the anorectal area, the swab should be inserted at least 4 to 5 centimeters into the anal canal. Okay. And then for irrigation or intravenous or intra-arterial catheters, okay, this is again done by an expert, no? So they could make use of endoscopic procedures for this. Okay? And then tissue, no? Tissue specimens, scrapings, or actual tissue samples. And you can also process that in the laboratory. Okay, for the containers, okay, for aspirates, they should be placed in sterile vials. For ulcerative lesions, like biopsies, okay, they can also be placed inside sterile vials without preservatives. Irrigation, intravenous, and intra-arterial catheter tips, they can usually be placed in sterile vials. Swabs, again, remember, 2 pieces, and they should be placed in sterile tubes. Do not allow them to dry. Okay. Fluids, syringe with sterile rubber stopper can be submitted. Okay, so this is the only specimen where we can store them in the syringe. But this is the procedure should be done within the hospital premises. And then for corneal scrapings, direct inoculation is usually done. Okay, we don't place them on containers anymore. Okay, so transportation time, remember for exudates and transudates, they should be submitted in the lab within 30 minutes from collection. As much as possible, it is still best if they are submitted in the lab in less than 30 minutes. If delay in transport is expected, you can refrigerate them. If swabs are used, you can place the swabs in trypticase soy broth, or you can place them in thioglycolate, and then you can culture them in Amy's or Stewart medium, or you can also use the ship's blood agar slant. No? So SBA is ship's blood agar. Okay, so we have the last specimen here. We have genitourinary specimen. So we can process cervical samples for female, urethral for both male and female, rectal, male and female. Also, the rectal samples can be paired with throat swabs. So the purpose of examining genitourinary samples is for the determination of sexually transmitted diseases, for the detection of vaginitis, urethritis, and the presence of childbirth infections. Okay, so the possible pathogens that we can come up with from genitourinary samples include Treponema pallidum, Neisseria gonorrhoeae, which is quite common, Chlamydia trachomatis, Gardnerella vaginalis, Candida albicans, and in some cases, herpes simplex viruses. Okay, so for Neisseria gonorrhoeae, which is quite common, they are gram-negative diplococci when gram-stained. They can be cultured on chocolate agar plate, which is an enriched media, and is usually stored in an environment with increased carbon dioxide present. You can also you can also grow them on modified Thayer-Martin media, which is a selective media that can inhibit growth of normal microbiota. Okay, so these are examples of transport medium for Neisseria gonorrhoeae. So we have the transgrow media, which is basically a chocolate agar plate, and the Gembeck system. So basically they are the same. Okay, so if you're going to use the bottle, this one of the transgrow media, it is usually it is not refrigerated. Okay. Remember, the organism is quite sensitive to low temperatures. It should be transported in ambient temperatures. Okay. So remember, if this one is used, the bottle must always be held up in the upright position, especially when the cap is off. So when you have opened the setup, this one, when you remove the cap, this should not be lying down like this. Okay, the bottle should be straight up. So it looks quite familiar, right? So we use this bottle for parasitology laboratory. Okay. Yeah, we use that to contain the NSS, but actually this is the main purpose for those bottles, no, culture bottles. Okay, so they should be held upright. Why? Because this bottle contains carbon dioxide gas. Okay, so it's heavier than air. That's why to allow it to avoid it from escaping, it should be held upright so that it stays down into the bottom of the medium. Now, if it gets tilted, if the bottle gets tilted, the carbon dioxide gas can escape. Okay. So this can be incubated at 35 degrees Celsius for 24 to 48 hours. Incubated, not refrigerated. Okay, so here is a table that I have extracted from Bailey and Scott. Okay, so this is actually around 8 slides. Okay, so this is a summary of what has been discussed to you today. Okay, so this table entitled Collection, Transport, Storage, and Processing of Specimen commonly used in the microbiology laboratory. Okay. So this table is divided into columns for specimen, container, patient preparation, special instructions, transportation to laboratory, storage before processing, primary plating media, direct examination, and comments. Okay, so I'd like you to go through each of those slides containing a portion of the table. Okay, read through it because it's a summary already. You'll come across acronyms. These are acronyms for culture media. You have BA, CA, MAC, CNA, you have BBA, LKV, BBE. Okay. What else? Okay, so remember to look for the meaning of this culture media. No? So include SSA, okay, HEA, EMB, MAC, okay. So try to look for the meaning of those, okay. It might be included in the quiz we're going to have, okay. So again, there are about 8 slides of this, but I will only show you one, for example. Okay. So remember that nothing is more important than the appropriate selection, collection, and handling of specimen for accurate microbiologic diagnosis. Okay. So the different samples that we process in the lab includes blood, we have respiratory tract specimen like sputum and nasopharyngeal swabs. We also process urine, CSF, stool, exudates and transudates, and then genitourinary specimen. Okay, so initially we do gram staining, we do smears, and then we culture them. For some cases, we do centrifugation. We work with the sediments like for CSF. For others, we directly inoculate them into our culture media. Now, after inoculation, we usually incubate it, and then we check out the results the next day. If we need to transport our samples, we need to or if there's a delay, we can refrigerate them or we can grow them on transport media. Okay. Nowadays, we have automated systems that can process all this specimen, particularly blood, in the laboratory, making our lives simpler, our work easier. Okay. Thank you for listening. I hope you were able to learn something from today's lessons.